Hi everyone, Dr. Hall continuing on with lecture 26. We've now finished our final viral STI, which was HPV, and so now we're going to shift gears and talk about reproductive cancers. Specifically, we're just going to remind ourselves what cancer is, and then we're going to talk about the male reproductive cancers in this mini lecture. So what is cancer? You should know this. We've talked about it a lot already in this semester. Maybe pause the video and see if you can recall all the things that we talked about. So cancer is when a cell starts misbehaving. It goes rogue in several ways. One is that it starts growing and dividing and making more copies of itself very rapidly. So it's growing rapidly. It also stops staying where it's supposed to be. So it tends to spread to other parts of the body where it doesn't belong. So that's the second thing. And then thirdly, it tends to not die. So most of our cells only have a certain lifespan after which they die, and then younger versions of them take over. But cancer cells are often what we call immortal. They will keep going and keep going forever. So what causes that to happen, right? So this is due to a genetic mutation, so mutation in the genes that tell the cell how it's supposed to behave. And so when they get mutated and their instructions are wrong, that's what causes the cell to misbehave. And so those genetic mutations can be due to oftentimes just bad luck. Statistical probability, the more times a cell replicates itself, the more likelihood that at some point in that copying of the DNA step of mitosis, it's going to make a mistake and lead to a genetic mutation. So one is just kind of bad luck, statistical probability, and the longer you live, the more likely it will happen. The other is that you could have an inherited bad copy of a gene, right? So there are genetic risk factors. And then the third would be you might be exposed to things that increase the likelihood of genetic mutations occurring. So carcinogens, right? Carci for cancer, gen for genesis, creating. Carcinogens, things like tobacco smoke, pollution, perhaps some of the endocrine disruptors that we've talked about. Finally, we've talked about how cancer can cause illness and ultimately sometimes death as well. And so there are two major ways that that occurs. One is that the cancer cells, which are growing and dividing so rapidly, they take a lot of resources. So they take a lot of oxygen and nutrients and basically end up taking it away from the normal cells of the body. So they're kind of monopolizing those resources, which is why people with cancer often get very thin and emaciated and tired. The other thing that can happen is that because they are invading into other regions, they can physically or mechanically disrupt the operation of other organs. So if you get a bunch of cancer cells growing in your lung, then you can't breathe as well. If you get a bunch growing in your liver, then your liver can't work as well. In your brain, same thing. So that disruption of normal organ function because they've invaded into those spaces. So that's what cancer is, right? All right. So the thing that I want to point out to you is that cancer overall is really common. There's a reason why we've all heard of it. There's a reason why we've all known someone who had it. So you can see in the red rectangle up at the top here that our lifetime probability of getting some type of cancer is about 44% if you're male-bodied and 38% if you're female-bodied. So almost half of us, more than a third of us, will get diagnosed with some type of cancer at some time in our lives. I want to point out to you also, so this list is of the most common cancers. So we see here breast cancer is very common cancer, and then down here we see prostate cancer. So your lifetime risk, if you're a female-bodied person, of getting breast cancer is about 12%, and if you're a male-bodied person, your risk of prostate cancer is about 15%. Cancer is common. We've also talked about how we treat cancer, so kind of the three-pronged treatment that we've had for decades would be surgery, right? So removing the tumor and checking the nearby lymph nodes because that's the first place that cancers typically spread. So we're going to check and see if it has spread into the surrounding region. We also have chemotherapy, so that's medication that kills cancerous cells, often by specifically targeting any cells that are rapidly dividing and multiplying. So one of the unfortunate side effects of chemotherapy then can be other cells which normally divide very rapidly also get killed by the chemotherapy. So that would be our blood cells, cells in the digestive system, right, which is one of the reasons why chemotherapy can cause nausea and vomiting. And your hair follicle cells are normally very rapidly dividing and multiplying, and that's why hair loss occurs, because those cells also get killed, right? So you can have a lot of significant side effects. So we don't like to give chemotherapy to people unless we need to. And then finally, we can also use radiation, which is targeting X-rays, specifically hone them in and kind of beam them at the tumor to try to kill those abnormal cells. We have to be careful because you can get radiation burns of surrounding tissues. And of course, radiation itself increases your risk of genetic mutations and cancer down the road. So we want to avoid it in really young people at high doses if we can. Believe it or not, many years ago, they used to use, I think it was in the 50s, they used to use radiation to treat acne in young people and teenagers. Worked really well to treat the acne. Unfortunately, then it also ended up causing cancer in many of them. So we have to be careful with that. We have some newer treatments for cancers that we didn't have a couple of decades ago. So hormonal therapy. So we've found that certain cancers can be treated with anti-hormone drugs, especially the reproductive cancers, because they are hormonally sensitive cells. They are cells that normally respond to hormones like LH or FSH or estrogen. We also have immune therapy, which is new. So we give antibodies that can target the cancer cells. So that's pretty exciting, brand new field of treatment for cancers. In general, with most cancers, the prognosis, meaning how you're going to do, is better if the cancer is localized and not spread. That might be in part due to the fact that it's easier to do surgery and remove it. It's easier to treat that one small area than to treat a large area. But it can also be that maybe that's a less aggressive cancer to start with, right? Some cancers tend to be a little bit lazier, a little, quote, less cancerous, or a little less rogue and wild than other cancers. So it's hard to know. We also have talked about cure rates for cancers. So when we look at survival data for cancers, the statistics show us 5-year survival rates. That's how we assess prognosis. We look from when they were diagnosed till 5 years later. So that doesn't always mean a true cure. Sometimes they still have some residual disease, or it may come back later, but that happens to be the way the statistics are currently reported. So now let's move into the male reproductive cancers, starting with testicular cancer. So testicular cancer is relatively rare. So you can see in the pie chart on the right, it's only 0.5% of all cancers in the United States. And in the table, you can see that in 2016, there are about slightly fewer than 9,000 cases per year and only 380 deaths. Now, if you're one of those 380 people, that is tragic. But just to kind of put these numbers, if we think about it as a population level in perspective, texting while driving kills about 6,000 people per year. About 40,000 people per year die from car accidents. And actually falling out of bed kills 450 people per year. So falling out of bed kills more people per year than testicular cancer. Now, granted, some of those folks are very elderly, but anyhow. So one thing that's unique about testicular cancer is that this is one of the few cancers that is more common in young people. So the age at which most people develop testicular cancer is between ages 25 and 40, reflecting that this is a hormonally responsive cancer, so you're more at risk for it when you have higher levels of testosterone. Overall risk for men is about 1 in 200 in the course of your lifetime, or 0.5%. And what you can see here from this graph, this is the incidence numbers of cases. It seems to be gradually going up a bit over time, although this lower bar down here, which is the number of deaths, has stayed very low. I also want to point out that the overall percent surviving 5 years is 95.3%. So that's a really high cure rate for testicular cancer. This shows you the age groupings again. So the median age at diagnosis is 33. That's very unusual for most cancers. Usually the longer you've lived, the more opportunity for your cells to make a mistake and have a mutation, right? So half of all cases of testicular cancer are diagnosed in people between ages 20 and 34. This is a close-up of that one chart that shows you that whereas the incidence of testicular cancer used to be less than 4 per 100,000 persons, now it is higher than 6. So on this graph, it doesn't look particularly significant, but that's a 50% increase. So that's quite a lot. We're not really sure why that is. Trying to understand risk factors for testicular cancer is tricky because it's relatively rare as a cancer, so we don't have as much data or information about it. Marijuana use does appear to double the risk in many studies. However, there are some other studies that shows it decreases your risk, so it's very controversial. Although some of those studies weren't well done. If you had ever smoked a joint, they lumped you in with people who smoke several times a day, every single day. So their methodology was a little flawed. If you have an undescended testicle, which we learned about in the beginning of the semester, so cryptorchidism, testicles aren't meant to be in the warmth of the body, that seems to increase your risk. Sedentary lifestyle also increases risk. We think perhaps because then testicles are warmer if you're sitting a lot of the time. We're not really sure. And there's also some early evidence that perhaps some of those endocrine disruptors we've talked about may be linked to risk for testicular cancer. So I mentioned earlier that overall the cure rate is 95%. So we're going to break that down and look at it a little bit more in detail. So in the pie chart on the left, this dark green here, this is the number of cases that are diagnosed when the cancer is just localized, confined to the primary site, which means it's still just in the testicle and hasn't spread anywhere. So 68% of testicular cancers are found at that stage. Testicles are relatively easy to observe, right? They're easy to palpate and feel. They're not buried deep within your body. So a lot of times if a lump develops on a testicle, either the person themselves or their partner will notice it. So they tend to be found in earlier stages because they cause symptoms. So then we can see another 18% are found when they've only spread to the regional lymph nodes, and then a much smaller percentage are found in distant stages. And so when you look at the survival rates, 99% of people in whom it is just local will survive this cancer, and 96% even if it's spread to the regional lymph nodes. That's phenomenal for a cancer. Even for distant spread, 73% cure rate. So for a cancer, this is really, really good, right? Cancers tend to be very dangerous. This is one of the potentially less dangerous cancers out there. This is an example of a young man with testicular cancer that has spread all throughout his body. So what we're looking at here on the left is a chest x-ray, and on each side here in his chest, it should be pretty much all black except for the little rib lines that you see that look white. All of these little round things that look kind of like ping pong balls, these are all individual tumors that were seeded by one cancer cell that decided to park itself in a lung, and then it started growing and multiplying and creating all these tumors. So this is somebody who has distant metastatic disease, right? It has spread to all these other parts of the body. So now I'm going to show you the chest x-ray of this same person after they were treated. It's amazing. So we can still see a little bit of abnormality in the lungs, probably some residual scarring from these tumors, but again, even when testicular cancer is metastatic, the cure rate is up in the 70s. So people tend to do relatively well with this particular cancer. Some people don't, and it still can be devastating, but many people do relatively well. So how do we diagnose testicular cancer? So the only screening test we have is for somebody to do a testicular self-exam, right? Testicles are relatively easy to notice, and so a lot of health and wellness groups thought, hey, we should encourage men to regularly examine their testicles and feel for lumps. That sounds like a great idea. And so perhaps you've seen these instructions on how you're supposed to examine your testicles, and you're supposed to do it once a month. And if you see any, feel anything abnormal, you should go to your doctor right away. So this may already starts to sound familiar to breast self-exams, right, which we also thought were going to be a good idea. It was interesting, I had a colleague who worked at a college campus one time that they did a campaign to encourage people to do testicular self-exams, and they called it Check Yo Nuts, and they handed out little bags of like peanuts or something with instructions. It was kind of strange, but cute. All right, so should we screen, right? So how accurate is testicular self-exam as a screening test for testicular cancer? It turns out it's pretty poor. So you can have some normal lumps and bumps on the testicles. You can have the epididymis, and a lot of men will mistake that as some type of tumor. You can have, as you know, a spermatocele or a hydrocele or a varicocele. There are lots of things that can cause a mass or a lump in the scrotum. And so when it comes to the accuracy and the test performance characteristics of testicular self-exam, it's not very good. And then we get an ultrasound, and then maybe they don't know for sure, and the guy is worried, so then they do a biopsy. And the more and more invasive we get, the more likelihood that we might accidentally cause harm. This should sound familiar to you. So when it comes to figuring out whether we should screen for testicular cancer, so is it common? Well, not very. Is it often asymptomatic? No. It usually causes symptoms, even if people aren't looking for them. Usually they eventually notice it. Is it serious? Yes, right? It's a cancer. It can be fatal. Is there a good screening test? So unfortunately, self-exam, lots of false positives, right? People think something's wrong and it's totally fine. Are diagnostic tests potentially risky? Yeah, right? So getting biopsies of your testicles, that could be potentially risky. Is there an effective treatment? Yes. But does finding it early result in significantly improved outcomes? Not so much, right? So even if it's already spread to the lymph nodes, you still have really high prognosis, really good prognosis. So for testicular cancer, right, even advanced cancers have a really high cure rate. And so all of the tests, the studies that look at testicular self-exam campaigns have found no difference in survival rates at all, and increased numbers of men coming in who are worried and they need additional tests, so that we're causing them anxiety, and we could end up causing them some physical harm. So overall, we do not recommend screening for testicular cancer. So if you own testicles and you were feeling guilty that you're not checking them once a month, you do not need to feel bad, right? You do not need to do that. Now, if without looking for something, you notice something in the shower, you're like, oh, that's definitely different, then yes, of course, get it checked out. Don't ignore it. But we're not going to recommend that men go looking for things on their testicles. It doesn't seem to help. So now we're going to move into prostate cancer, which is very different in many ways from testicular cancer. So prostate cancer, unlike testicular cancer, is very, very common. So new cases here, let me change my color. New cases, 164,000 a year. Testicular cancer was fewer than 9,000 per year. So this is a very common cancer. It's usually one of the top 3 per year. Similar to testicular cancer, it tends to be not highly fatal, but in this case, it's for a different reason. It's not because our treatments are super effective, like for testicular cancer, although some of them are, but it tends to be a slow-growing cancer, relatively speaking. So overall survival rate, look, 98%. Again, really high survival rate. Primarily, this cancer affects older men. So we've got most diagnoses are ages 65 to 74. And we've also been seeing a decrease in cases, decrease in incidence of prostate cancer over time. So that's also different from testicular cancer. So prostate cancer, when you think about the anatomy, it does often cause symptoms. So I'm going to outline in yellow for you here. Oh, that was a bad choice. Let me do green. All right, so here's the prostate here. I don't know if you can see that. Let's try dark blue. Here's the prostate, and it's surrounding the urethra, right? We've got the ejaculatory duct coming through it and the prostatic urethra. So here's your urinary bladder here. And then when urine leaves, when you go to the bathroom, urine has to travel through that prostatic urethra. The urethra travels through the middle of the prostate. So you can imagine that if you had a big tumor somewhere in your prostate gland, that might start pushing on the urethra and making it hard for you to urinate. And in fact, that is not uncommon. So prostate cancer will not uncommonly cause some symptoms. We also can find it on screening tests. So there is a blood test, which doesn't have great accuracy, unfortunately. We can also find it by doing a rectal exam, because you can actually feel the backside of the prostate through somebody's rectum if you put your finger up into it. So doctors can actually screen for prostate cancer by doing a rectal exam. So we tend to find prostate cancer early, which we're kind of showing you in the pie chart on the left, even more so than testicular cancer. So more than 80% are found when they are localized and just confined to the primary site, and then another 12% are found when they have just spread to the regional lymph nodes. In those two cases, look at the cure rate. So the 5-year survival is 100% for people with localized or regional spread. So that's incredible, right? It responds very well to treatment. And some people actually, it seems like they don't even need treatment. It's just such a slow growing cancer. Now, not all prostate cancers are the same, however, and you may have already noticed that if you have distant spread, which is a minority of the cases of prostate cancer in this country, but if you do, that cancer seems to be much more aggressive, much less likely to respond to treatment. So the aggressive prostate cancers are the ones that tend to spread and metastasize, and they tend to be very difficult to treat. So the 5-year survival is very low at 28%. Fortunately, relatively few cases are that type of prostate cancer. So when it comes to screening for prostate cancer, so they did a study and they said, okay, out of 3,000 men that are screened, we will save the lives of fewer than 3 men. 90 to 120 men will get erectile dysfunction as a result of the treatment. 6 men will get a heart attack as a result of the treatment. 3 men will get blood clots as a result of the treatment, and 1 man will die. So you potentially save 3 lives. You end up accidentally killing 1 person and accidentally causing erectile dysfunction, heart attacks, and blood clots in some other men. For that reason, screening for prostate cancer is not routinely recommended. It's controversial, right? Because certainly we'd love to have you have a 100% prognosis instead of a 28%, but we're not sure that those two types of cancers are even the same thing. So it's very controversial. It's not routinely recommended. If we use our typical criteria that we talk about in this class, it is common. It's not often asymptomatic, although it can be. It's not usually serious. The screening test, I have to tell you, is not very good. And diagnostic tests and treatments can be risky. There is an effective treatment, but finding it earlier doesn't always seem to result in improved outcomes. So this one is controversial. So in summary, testicular cancer is relatively rare, but seems to be becoming more common. It usually causes symptoms. It's highly treatable, even if advanced, for cancer, and so screening is not recommended. For prostate cancer, it is very common, but we see very high survival rates even if it's untreated in people with kind of that more localized, lazier type of cancer, which is hard to know when you first diagnose it what it is. It often causes symptoms. It can be highly treatable, but treatment can cause significant harms, as we saw on that slide, and may not give you a significant benefit. So screening for prostate cancer is controversial. So in the last part of this lecture, we will talk about the female reproductive cancers.